of eminent treasure in this field. Thank you very much.
Okay, thank you, Dr. Reza, thank you, Dr. Rafi, thank you, Dr. Anna. Thank you, chairpersons. Welcome, Sir to our university. I'm very delighted to be today here with my dear colleagues from the gynecology department. And so, my first slide says, what I'm doing here, I'm just a surgeon, I'm not a gynecologist. Am I lost? Why I'm here today, just here with the gynecologist, obstetrician, surgical oncology doctor, what I'm doing here. So let's see what I'm doing here today. Last year, I wrote that slide, the gynecology department too, in oncology in Mansour University Hospital, about the problem of ovarian cancer in Egypt, and we had about a study of 500 cases in Egypt of ovarian cancer, and we have just seen how many of them have been dealt with according to international guidelines, and the results were so disappointing that we have only about 4.5% of them are dealt with according to international guidelines, and we discussed that last year regarding lumpectomy, lymphadenectomy, incision, total hysterectomy, and we discussed all that. I think that slide that is very disappointing will change soon by the efforts of Dr. Rafi, Dr. Saeed, Dr. Anas, and Dr. Reda, and all the colleagues in the gynecology department to emphasize the importance of the presence of gynecology oncology team. I think we'll have a different slide like that in the near future. I hope so. So, why I'm here today? Because ovarian cancer is a unique tumor. It is not like other tumors. It's usually present in advanced stage. It involves many organs, and those organs are sometimes outside the scope of general gynecologists. And we have a very bad term in oncology, debulking. We are always accused of doing debulking unnecessary surgery in surgical oncology in many cancers, just like surgical draining or removing something that have no value to add for the patient. But in ovarian cancer, that term is very important. Debulking has to play a very important role in surgical management of ovarian cancer. For early ovarian cancer, studies focusing on early stage disease found that gynecologists oncologists are more likely to carry out optimal staging. And optimal staging will lead to less use of chemotherapy into early stage disease, and we'll discuss that in the next slides. But the problem is that even in early ovarian cancer, the staging is often suboptimal because malignancy wasn't suspected, because there is no role for biopsy in ovarian masses. We emphasize that for all our radiologist colleagues and the young surgeons and the young gynecologists, that if you have an ovarian mass and then the radiologist says to you, go and proceed for fine needle aspiration or for local biopsy in early disease, this is very critical, and that was something that's done routine outside the guidelines, because just you are going to rupture the capsule and do spelling of the tumor, and this will upstage the tumors, and there is figo staging in the new one. In 2014, they add something for that, especially in the new figo staging. So, in the primary surgery,
You don't advise CT guided biopsy?
Yes.
You don't advise?
Of course, we don't advise at all. There is no role for biopsy. This is the NCCN guidelines. In 2013, it is the same in 2015. That just when I suspect ovarian cancer, I proceed for a staging laparotomy or laparoscopy or whatever, but never proceed for staging laparotomy. Just I do spelling of the capsule, and I upstage the tumor from 1A to 1C, and the patient may have unnecessary chemotherapy. It may be staged as 1C, and then the patient have chemotherapy, and she is not indicated to have so. So there is no role for biopsy at all in all the guidelines, either the NCCN guidelines or the ESMO guidelines for preoperative biopsy. And that's a problem.
That's it.
Yeah.
In early stage ovarian cancer.
Yes, in early stage.
This is to be emphasized.
Yes, I'm speaking about early stage. In advanced stage, I'll say the role of biopsy. This is early stage. If I don't have omental cakes or nodules, if I'm going to do surgery, so please don't proceed for biopsy. Here there is a role for frozen section we can discuss later on. So, I'll just take a few moments to discuss this. This is something that I'm very proud of. This is the registry system of Oncology Center in Basel University. We have been working on that registry system since 2005 till now, 10 years. We can celebrate 10 years this year of this registry system. It is one of the strongest systems all over Egypt, not all over Mansoura, and I think all over Middle East, where every single detail about the patient, the age, the laboratory investigations, the radiology, the follow-up visits, and everything is just registered every time the patient comes and the pathology. So we have like a very, very precious bank of data that we are doing now, carrying on many investigations depending on this bank of data. So Dr. Muhammad Arfa and the colleagues in pathology always help us in that. This is a case undergoing hysterectomy, oophorectomy, appendectomy, and peritoneal sampling, and it was T1CN0MX. She is stage 1C, at least fecal staging 1C. This is another case we have done, and she was T1AN0MX. This case will not have adjuvant therapy later on. If she is low-grade tumor and just T1AN0, she will not have the 6 cycles or the 3 cycles of chemotherapy after surgery. And just if I had a biopsy before that from the tumor, I'll spell she will be like 1C, and she may have chemotherapy later on. So this is very critical. Don't have a biopsy from early stage suspected ovarian cancer. So this is a case of early ovarian cancer. We are speaking about suboptimal staging. She is just C1A like the last case, C1A, but that was N0. That one we have like 2/7 infiltrated lymph nodes and 1/6 infiltrated lymph nodes, and shows she was N1 and she is stage 3 and she must have adjuvant chemotherapy. So just acute staging, upstaged here from T1, the same patient from stage 1 to stage 3C, and so she will have chemotherapy which will differ for her from prognosis for sure. Another case, T3N1, just the lymph nodes were in the omental deposits. So, for active staging in early ovarian cancer, I should have the uterus, total hysterectomy, of course, not subtotal, bilateral separation oophorectomy, omentectomy, iliac lymph node sampling, or systemic lymphadenectomy, we'll discuss that later on, para-aortic lymphadenectomy, sometimes peritoneal stripping and appendectomy as well, with cytology, of course, from the start. So, the first step is exploration. We must do thorough exploration of the abdomen. Just sometimes we proceed and open the abdominal cavity, and we are encountered with a large ovarian tumor. Oh, this is very nice. It comes out, and I proceed for oophorectomy or hysterectomy, and I don't do thorough exploration of the abdomen. Thorough exploration means exploring every side, from the diaphragmatic surface down to the pelvis, underneath the pelvic surface, the spleen, the liver, the portal lymph nodes, the aortic region, the small intestine must be explored one loop by one loop, not just like putting my hand like that. I must get out all the small intestine and explore very precisely every loop, and explore the colon, the transverse colon, the rectal, the cecum, because sometimes we have some tumors missed, not doing that. The second step I want to emphasize on is when I'm doing like a multi-organ resection like ovarian cancer, when I'm doing like hysterectomy, oophorectomy, omentectomy, peritoneal sampling, appendectomy, sometimes other organ resections, I must precise for a routine stepping, like I'll do the hysterectomy at first, then the omentectomy, for example, then the right iliac, then the left iliac, then the appendectomy. Why I emphasize on that? Because sometimes when I have a multi-step procedure like that, of 6 steps or 7 steps, I really sometimes forget to do like omentectomy. So you can proceed for hysterectomy, and then iliac lymph node sampling, and then aortic lymphadenectomy, and peritoneal sampling, and just you forgot to remove the omentum after 2 or 3 hours, because you are not accustomed to do every step by step. So that happened, and I saw that before. The solution is I must standardize my steps. I do the hysterectomy first, and then I proceed for omentectomy. This is the standard that must be done. Even if there is any problem in the anesthesia, I can omit the other steps, and then I proceed for the lymphadenectomy, and then lymphadenectomy side by side, the side of the tumor first, and then the contralateral side, and then I'm going to the aortic lymphadenectomy, and then the peritoneal stripping. If I standardize the steps, I'll never forget something. I saw people forgetting that, and they know that there is a rule, but they just forgot because this is a very lengthy operation. So, procedures that may be considered in all stages and in advanced stages: radical pelvic resection, bowel resection, diaphragm stripping, splenectomy, partial hepatectomy, cholecystectomy, gastrectomy, cystectomy, ureterocystectomy, distal pancreatectomy, and that's why I'm here today, because I think this is our business. I think we all agree about that. Yeah.
You don't leave anything for the patient?
I'll speak on that now. So, what's the role of oncosurgeon in the gynecology management team? Without cases of advanced tumors, the term debulking, we said that is a very bad reputed term in oncology, but not in ovarian cancer, not in neuroendocrine tumors, okay, not in renal cell carcinoma. Sometimes we have to do debulking. This topic of controversy, no residual disease as a completion of surgery has constantly been shown to result in improved overall survival and progression-free survival. When members of Society of Gynecological Oncologists were asked what they consider optimal site reduction, some define as no residual disease, 13% divide as half centimeter or less, 60% as 1 centimeter or less, 8.72 centimeter or less, and one used other criteria I don't have. But according to the gynecology group, optimal site reduction is defined as the largest residual tumor nodule measuring 1 centimeter or less. This is the definition which is most widely accepted among gynecologists. So, debulking have got pros and have got cons. What are the cons? The tumor biology and its ability to respond to chemotherapy is more important than the type of surgery performed. I think this always, when medical oncology said for us, don't do debulking, we have other criteria. Chemotherapy will be better because the tumor biology is the mainstay, not the surgery. And they said for us, survival is better with less residual disease. We agree with you, but when you do aggressive and ultra-radical surgery like you do, not leaving anything for the patient, as Dr. Reda said, will this improve survival? Also, the efficacy and variety of different chemotherapeutic agents have increased, like platinum agent combined with taxanes, and several second-like agents like toxicant, like doxorubicin, gemcitabine, and bevacizumab. And new combinations always rising, like that one in ASCO in June 2014. 2 experimental drugs, a combo of them have increased survival. So in Scotland, Scottish, and they are still part of the United Kingdom, we are all happy about that really here. I don't know why, but we are happy. That Scottish trial said that if debulking is associated with increased progression-free survival, but it is for patients who are already with this extensive disease from the start, not for the advanced cases. The authors conclude that tumor biology was a major determinant of progression-free survival, and the optimal surgery couldn't compensate for that. And they said, they are part of the United Kingdom, they said that patients outside the United Kingdom were more likely to undergo optimal site reduction than those from within. Progression-free survival wasn't different in the groups undergoing surgery outside the United Kingdom and in the United Kingdom. I don't know why always the United Kingdom, the medical oncologists are ruling. The surgeons are not so enthusiastic about primary surgery. Even I think there is a new trial, the CHROUS trial in Birmingham, and they said that neoadjuvant surgery is better than surgery. Always in the United Kingdom, they are in favor of chemotherapy against other Europe and USA and Japan and something like that. This is specific for the United Kingdom. Always a microarray analysis of 44 advanced ovarian cancer. They are speaking about tumor biology. This is different, as Dr. Muhammad had said. So we as surgeons have to defend our debulking. We have to work, and so we said that larger tumors have poor revascularized area, thus decreasing exposure to cytotoxic chemotherapy. Also, that large tumors have lower growth fraction, and we all know that chemotherapy will work better with tumors that have a very high growth fraction. And so, site reduction can remove chemo-resistant chromophagous cells, causing the small residual disease which have increased the growth fraction to be more sensitive to chemotherapy. Also, we are speaking about reducing the adverse metabolic consequences caused by this tumor, like improving psychological status of patients having a bulky tumor in his abdomen and marked ascites, enabling them to eat better. Among other functions, tumor removal have also hypothesized to enhance immune function. So we are in favor of removing the primary tumor. In 2004, the consensus statement on managed ovarian cancer from the Third International Gynecological Cancer Intergroup, ovarian cancer, they said upfront maximal surgical effort at site reduction with the goal of no residual disease. Patients with stage 4 ovarian cancer also experienced improved survival when undergoing aggressive cytoreductive therapy, and most studies now are in favor of cytoreductive therapy except for the UK. So, the criteria for non-stability, in report of patients in Johns Hopkins Hospital, they said what are the criteria of non-stability? They said that if ascites is greater than 1,000 milli, and we always encounter cases with marked ascites, carcinomatosis, cutaneous carcinomatosis, splenic involvement greater than 1 centimeter, omental extension to the spleen, parenchymatous liver disease, disease involving the portal hepatis, bulk disease involving the diaphragm. So that were considered the criteria of non-resectability for ovarian tumor. If I find that, I go to have neoadjuvant treatment. But still, can obese patients be optimally debulked? They found that in Johns Hopkins Hospital, the overall ability to achieve optimal debulking was 92.2. Even patients with 5 high-risk factors still had 80% ability to experience optimal debulking. Therefore, the reward is most patients can probably be optimally debulking when treated by the right surgeon, or gynecologist, of course, in the right institution. Rated optimal site reduction range from 20 to 90% with high rates of care when patients are managed by specialists who are trained in ultra-radical or aggressive surgical methods. So what is irresectable for you may be resectable for others. And we say, again, for Dr. Anna's statement, that in advanced ovarian cancer, I have a biopsy if I'm going to proceed with chemotherapy. But who will decide that we are going to proceed? The team which is specialized in gynecology surgery. When the team say that this patient will not benefit from cytoreductive surgery, we will refer to chemotherapy. Otherwise, if you can do, Dr. Rida or Dr. Rafiq can do that, so proceed for cytoreductive surgery. Okay? The problem of ovarian cancer is that many surgeons don't believe or don't know the concept of optimal debulking in ovarian cancer management. Just patient coming to a surgeon with ascites. For us in surgery, most ascites are stage 4, and so that advanced disease and refer for chemotherapy. And medical oncology never says no. Okay, and so this is not the problem in ovarian cancer. Ovarian cancer, I can have patients with ascites and still stage 1. So many surgeons just don't know that. And most general gynecologists believe in the value of debulking surgery, but they can't achieve it. I'm speaking about general gynecologists, not gynecologists well trained in gynecology, like the team who is organizing the workshop. So I'll speak in a statement about our experience in multi-organ resection in ovarian cancer, starting from the simple procedure, appendectomy, which is a minor procedure and can be performed safely with minimal complication. When we do appendectomy, we do appendectomy if it is clinically involved, suspicious, or in mucinous tumors. You must remove the appendix in mucinous tumor, and that's what I said to Dr. Khalafa. It differs serious from mucinous because in surgical, if I know that's serious, I'm going not to remove the appendix if it is free, but even in mucinous tumor, if the appendix is looking grossly free, I'm going to remove the appendix. Also in the pseudomyxoma protonei, I must remove the appendix. Pseudomyxoma protonei is now widely accepted to be originated from the appendix. So if I have a male, I remove the appendix for sure. A female with ovarian tumor and pseudomyxomas and gel-like material over the abdomen, and I do believe that the origin is ovary, mostly the origin is appendix. So I have to remove the appendix in pseudomyxoma protonei as well before doing hyping. The problem is how to diagnose mucinous tumor preoperative. We said we have no rule for biopsy. So how I diagnose mucinous tumor? I have some criteria. For example, the mucinous tumor have larger size than serous tumors, the gel-like material that I see in the abdomen, and the tumor markers. We don't do now the CA125 only for epithelial cancers in the post-menopausal patient. We must add CEA because CEA is rising, and there is many toxin pathology now that there is no primary mucinous tumor in the ovary at all. There is serous and there is mucinous metastatic from other part of GIT. So I must thoroughly examine the GIT tract before considering a primary mucinous tumor of the ovary. This is very important. You may find something in the rectum, in the sigmoid, in the right colon, and so please, if I have a larger tumor, suspecting mucinous tumor from radiology, I should have, and we do routine in our center, CEA and CA125 prior to that. If CEA is high, we suspect mucinous tumor and we must remove the appendix and thoroughly examine the GIT tract during surgery. So this is a case we have done. And the appendix was removed and it was free from tumor tissue because it was mucinous cystic adenocarcinoma of the right ovary, and the appendix was free from tumor tissue that we have done. It was referred from gynae department. What about bowel resection? The most part is performed if involved by the primary tumor, and usually it's the rectum or sigmoid in the pelvis which are involved by the primary tumor. Transverse colon or small intestinal loops are usually involved by the omental disease or in the process of peritoneal carcinomatosis. Avoidance of bowel resection, that's a very important point because sometimes we are encountered with very large omental cakes and it seems grossly that it is infiltrating the transverse colon. And for us surgeons, our hands are usually very fast, just clamp and remove the transverse colon. What's that? And do resection anastomosis. But really from our small experience, I do believe it is a peritoneal disease. If you are going to dissect one by one and go through the serosal, subserosal plane and remove, you will remove about 90 to 95% of the omental cakes without having to do resection anastomosis in the transverse colon. Just be calm try to raise the omental cake and go in the right planes, and you will dissect. This is not the case in all patients, but in most of patients. Don't just proceed because the anastomosis have some problems we are going to speak about now. Okay, so try to preserve the colon as much as you can. Sometimes during doing the lymphadenectomy, we have just to injure the inferior septic artery. That doesn't happen with us, but it may occur, of course, and this causes some ischemia of the transverse colon, like that. This inferior septic artery is totally exposed in lymphadenectomy. This again, we are playing with it. So, for us in gastrointestinal resection, we must now, it is routine and guidelines, to send the margins for frozen section to be sure that we have adequate negative margins. That's in the primary chronic tumors or the primary small sinus tumors. Is it a must in ovarian cancer? No, because we said before that in optimal debulking we have to leave less than 1 centimeter, 1 scale or less. So I'm not searching about microscopic negative margins. So don't exhaust the pathologist and don't exhaust yourself by sending the margins in ovarian cancer for frozen section. But in GIT primary, you must do that. This is for surgeons. Okay? But really, do positive margins affect the of anastomosis? There is many trials about that. If I have positive microscopic margins, it affects the anastomosis. So this is a problem. For example, that case where omental cake were dissected from the spleen and the colon, and so we spared that, and splenectomy happened, and we done splenectomy. Optimal debulking was done for that. What are the problems with anastomosis? We are speaking about not rushing for colectomy, because always surgeons rush for that. Ovarian cancer disease, old age, hypoalbuminemia, and malnutrition is always happen in advanced ovarian cancer. And radical surgery with multiple resection is major surgical trauma. And usually we have some cases who have before chemotherapy, interval debulking. And so this is a case, for example, we will have done anastomosis. The patient post-operative was feverish, tachycardic, leakage wasn't evident, low output fistula, and so we did CT, and we said if collection were happening, tube drainage will be done, PRSME. And then, after that, they presented with fecal fistula, no improvement during conservation for 1 week, the same amount of fistula outcome, difficult controlling of the wound, no improvement in patient renal condition, so the decision was exploration, detection of the leakage point at site chronic anastomosis, and we go out with double barrel colostomy. So we have sometimes the anastomosis to be lost. This is other case, high-grade ovarian serous carcinoma infiltrating the left ovary, omentum, and subcillosa. This is what I'm speaking about. It is the subcillosa only. You can dissect and remove even the cirrhosa, no problem, of the upper rectal septic margin, and the lower rectal septic margin was free. And that we have to do low anterior section for that case. Case of ovarian cancer underwent expression through midline incision, and hysterectomy, large omental cake infiltrating the transverse colon. So the surgeon excision with resection of infiltrated part of transverse colon. What about the pathology? The pathology said for us that the tumor was involving both ovaries, both tubes, uterus from outside, infiltrating the transverse colon from outside, subcillosa again. That's my message. Don't rush for doing transverse colectomy. You can preserve the colon in many cases. Okay, like that one. He may, if he spends just more time doing dissection of omental cakes, he will preserve the transverse colon. That case, local recurrence of adenocarcinoma was endometrioid adenocarcinoma of the ovary. That was involving the cirrhosis of the rectum. With malignant fistula, in that case, there is no place. I must do anterior section for that. This is what I'm speaking of. Malignant fistula and the infiltration of one end. Again, this is case with serosal tears. So what if I do serosal tears? That's nothing. I just do simple repair, and the patient will start oral whenever he pass motion. What about spleen? Splenectomy is usually performed if the upper abdominal extension of the disease will involve the spleen. I should remove the spleen. And sometimes just a splenic injury may occur during omentectomy. When I'm doing omentectomy and I just do traction for omentum, and like some junior or even senior and doing like tough traction for omentum to do it, you just injure the spleen and you do splenectomy. So please, I know this is a very lengthy operation, but please be wise and just step by step. So that was a case with suspicious spleen in the appendix, and the diagnosis, we moved them, and they were free and active lymph nodes, but we do optimal staging. It was low-grade papillary serous carcinoma. Again, that was a case where there was 3 out of 5 dissected lymph nodes from splenic hilum, and one of them was infiltrated and the spleen was removed. There was some lymph nodes in the splenic hilum, and so around the splenic artery and vein, and to dissect and do optimal debulking, I have to remove the spleen. The spleen itself was free, but the lymph nodes in the splenic hilum were positive, and I was trying to achieve optimal debulking. What about the urinary bladder, ureters and cases? Total cystectomy is rarely indicated in our practice. If I have to do pelvic excenteration, anterior pelvic excenteration, I prefer to close the patient and refer to have neoadjuvant treatment, not to do primary from the start. Partial cystectomy usually is done and just like simple repair or suprapubic case, and Dr. Nasr have given a lecture about that. Usually done. Ureter can be infiltrated sometimes with a tumor or rarely injured during retroperitoneal lymphadenectomy when we dissect the ureter or down in the cervical stump. Kidney is rarely subjected to complications except if renal artery or vein is injured in lymphadenectomy. So that was a case where I did retroperitoneal injury and we repaired over a stent, and so we removed the stent off after that by ureteroscope. So this is the ureter, which is sticked in lymphadenectomy. This is the pterygoid nerve and the pelvic lymphadenectomy. This is our work, pterygoid nerve subjected. What about hepatic resection? Hepatic resection in Egypt is like a nightmare because almost always we are dealing with cirrhotic livers. This is not the criteria. First of all, Dr. Adel here, when I'm doing radiology or CT for case of ovarian cancer, I must say if these hepatic deposits are just subcapsular implants or really parenchymal deposits, because this is stage 3C and this is stage 4, which is totally different in management. Okay, and even for me as a surgeon, if it's just subcapsular deposits, I'll go and do stripping. This is simple, like not child play, but this is a simple procedure. But if it is intraparenchymal, I have to have my ultrasound and special precautions for that. So please, when you have like metastatic disease in the liver, go and revise the CT with someone who is a specialist and he is efficient, and ask him if the hepatic deposits were subscapular or intraparenchymal. Sometimes also a problem that we encounter in Egypt when I have a ovarian mass and hepatic focal lesion in cirrhotic liver, and we encountered that problem about I think 5 or 6 times, that you have primary HCC, which is very endemic in this region, and ovarian mass. Like sometimes we have the ovarian mass benign and HCC, or malignant ovarian mass and HCC. It is not always metastatic. So when you have hepatic focal lesion in cirrhotic liver, you must do the alpha protein and be sure this not HCC, because if it is HCC, no role for surgery now, and the patient will have cirrhotic liver and that will be very morbid. Almost always metastasis occur in normal liver, not in cirrhotic liver. Okay? So that some of our work, bilateral ovarian biliary carcinoma, infiltration of omentum, hepatic focal lesion was removed by similar tumor tissue and show stage 4. And another case where we have removed the transverse colon, second lymph node, and liver nodule as well was removed from it. So that's how we resect the liver, and then we control the pedicle first of all, and then we do intraoperative ultrasound. There's a tumor, and after controlling of the pedicle, it is not a bleeding case, and this is normal liver, so it will be easy. And then we are going to resect the liver either by ligature or by just scissors, finger fracture method. I must have a watch because I will control the pedicle only for 10 or 15 minutes. After 15 minutes, I must remove the pedicle, its clamp, so not enter the liver in ischemia. And then I remove the tumor like that, and there's an nodule which is very evident, and we removed it completely successfully in the case of ovarian cancer. In the hepatic resection, really, in our center, we don't have experience in the hepatic resection, and that's why I'm traveling I'm not attending the conference, because I'm going to have some space for hepatic resection. So neoadjuvant or primary or chemotherapy is still clinical trial, it's a poor performance status. If I'm going to have permanent diversion, please proceed for neoadjuvant first. Even on Facebook, while I'm studying Facebook, some colleague in USA, he said that, please, I was here in USA attending and they emphasize the role of neoadjuvant therapy. And I said, okay, depending on people sometimes. So even on Facebook, it is still chemotherapy or surgery. Do I have a prediction model to say if I'm going to have resection or not? The results after all those papers about prediction models, that still I don't have an ideal prediction. Always, the last thing is about subtotal hysterectomy and leaving residual tumor. Almost always it is compressing the base of the bladder, contacting the rectum. Subtotal hysterectomy, again, squamous cell carcinoma is cervix, and we are doing subtotal hysterectomy for cervical cancer, infiltrating the rectum and the bladder as well. Again, infiltrating the lower uterine segment, residual recurrent uterine stomach, infiltrating the rectum. Almost always in the cervical cancer doing subtotal hysterectomy, I don't know why really. That was a case referred from gynae department, underwent suboptimal surgery outside, not in the gynae department, and still we have like bulky lymph nodes that we have to remove, like that, and cervical stump to remove as well. And this is a bulky lymph node over the IVC that must be removed. This is our work considering lymphadenectomy. This is the left renal vein, the inferior artery, the aorta, and the IVC, the ureters, this inferior artery. And this is the left renal vein. I think Dr. Anas was with us in that case. And lastly, this is our multidisciplinary team. We are always speaking about multidisciplinary team. We are from the surgical department, Dr. Samir Shama and Dr. Muhammad Awad from the medical oncology, Dr. Wagdi from the pathology department, and some surgeon is laughing here, Dr. Islam, I don't know why he's laughing. And just we discuss every case by case single on our system, and then we have to write the diagnosis. And thank you.